Hello and welcome to JAMA Health Forum Conversations. I'm Dr. Sandro Galea. I serve as the Dean of the School of Public Health at Washington University in St. Louis. I also serve as Editor-in-Chief of JAMA Health Forum, a peer-reviewed, open-access online journal focused on health policy, healthcare systems, and population health, one of the specialty journals in the JAMA network. Today we are talking about innovation in pharmaceutical policy in the United States. The U.S. drug system is extraordinarily complex, involving discovery, development, marketing, access, and affordability, all with distinct policy challenges. Recent efforts like Trump RX and provisions of the Inflation Reduction Act have reopened debates about how to ensure effective, safe, and affordable drugs reach patients. To discuss this, I am joined by Dr. Aaron Kesselheim, Professor of Medicine at Harvard Medical School and a faculty member in the Division of Pharmacoepidemiology and Pharmacoeconomics at Brigham and Women's Hospital. Dr. Kesselheim leads the Program on Regulation, Therapeutics, and Law, Portal, and his research has shaped contemporary understanding of how regulation, evidence, and market structure influence drug pricing and access. His work has appeared widely, including extensively in JAMA and JAMA Health Forum. I am delighted to be speaking with him today. Welcome, Aaron.
Thank you very much, Sandro. It's a pleasure to be here.
So let's start with the big picture. You have often written that we need a system that encourages meaningful innovation, not just more drugs. How do we balance encouraging discovery with ensuring affordability and equitable access?
That's a really big question and a very important one. I think that, first of all, we need to try to have more clarity about where true innovation comes from. And that's something that we've tried to do a lot of work on in my Portal research group that I help run, where we try to uncover the various sources of innovation. And one of our consistent findings is that meaningful innovation tends to come from publicly funded science that goes on at academic medical centers and government laboratories. And so I think that, first of all, recognizing the origins and the provenance of important innovation is the first step. Another step is ensuring that the incentives and various ways that the systems are designed to try to encourage useful innovations to come through, which means ensuring that the FDA has standards that allow physicians and patients to distinguish high-quality drugs from not high-quality drugs. I mean, the reason that drugs are tested in rigorous ways is because the FDA requires them to be. And if the FDA stops doing that, then we're going to get less useful information. And then finally, we need payment systems that are also geared towards making sure that we pay for value and that we pay appropriately for innovations that make a difference, and that we don't necessarily pay excessively for innovations that don't. And I think when you put all of those things together, then you can get a system that is optimally designed towards getting innovation that is maximally useful for patients.
Let's zoom into something you've written a lot about. You've written a lot about how patents and exclusivities are used strategically to extend market dominance and effectively raising prices. And in one of your recent studies, you looked at FTC actions on prescription drugs over 2 decades. So tell us a little bit about that and what you found about the gaps that remain here.
Yeah, I think that the intellectual property system that we have is a very important part of this story, because prescription drugs are covered by patents, and that's what helps prevent competition in the form of generic and biosimilar drugs from coming on the market. It provides some protection for brand name drugs to allow them to make appropriate revenues for an appropriate period of time. But then those market exclusivities are supposed to end and allow a more competitive market with generics and biosimilars. And the availability of generics and biosimilars have saved this country literally trillions of dollars over the last few decades. And the problem that you identified is that in the US, sometimes we allow patents to be issued too easily for drugs, and there are too many low quality or potentially invalid patents listed with the FDA that prevent timely competition from generic and biosimilar products. So as we talk about the question of innovation and to try to ensure that we have a maximally efficient system, we need to make sure that we're not spending excessive amounts of money on drugs for which the market exclusivity periods should have already expired, and to try to ensure that the patent system works to appropriately protect new innovation, but can't be leveraged through various strategies to try to extend market exclusivities indefinitely for drugs that are already supposed to have adequate competition that can lower prices and increase access. So that's what the FTC has been trying to do in some cases. They, for example, based on work that Will Feldman and Sean Tu and others in the Portal Group have done, the FTC has moved to try to take off, to delist certain patents that cover medical devices that are used to extend the exclusivity of inhalers and GLP-1 products and insulin products without actually covering the drug at all. So, these are ways that the system can be misused. And I think that we need to think about ways of trying to ensure that the system has appropriate balance and oversight to ensure that that doesn't happen in order to try to promote innovation.
Let me switch to affordability for a second, and particularly Medicare negotiation under the Inflation Reduction Act. You wrote a recent paper in JAMA Internal Medicine looking at changes in Medicare Part D plan after the IRA. So, what do you see as early signs of its impact, and what should we be looking for next?
I think the Inflation Reduction Act is one of the most transformative pieces of legislation with respect to the pharmaceutical market in the US that we've had in recent years. First of all, it's done a couple very important things. As we've seen now with 2 years of negotiation, there are now 25 drugs that have been negotiated under the Inflation Reduction Act, and we have seen substantial reductions in the prices that those drugs are made available to in Medicare. The other thing the Inflation Reduction Act did was that it capped out-of-pocket spending for patients who might need very expensive drugs. And that cap in out-of-pocket spending in work that we're doing, led by Chris Kai in our group and Ben Rome, it does appear that what we're seeing is greater use of expensive but very useful cancer drugs or other drugs in Medicare because of these out-of-pocket caps. So I think that the Inflation Reduction Act has been a success. And actually, the major problem with it is that it is relatively limited in scope, in that, it's a relatively small number of drugs that are being negotiated at the ends of their exclusivity periods. They have to have been on the market in, 9 to 13 years, and it only applies to Medicare. I think that the Inflation Reduction Act has been a great success and is a model for how we can get to fairer prices for drugs, both in Medicare and potentially extending it to the private market as well, and maybe happening sooner than is currently designed in the legislation.
Let me switch to drug shortages for a second, which remain a persistent challenge, particularly for low margin generics. So, from a federal policy approach, what are approaches towards making supply chains more resilient and to make sure that we're not undermining incentives for innovation in that space?
Yeah, I think drug shortages are a major issue, and this brings us to the stability and resilience of generic drugs, because in most cases, shortages relate to older drugs that are generic or are, some of the core products that hospitals use. And these products are manufactured and sold at prices that are very close to the cost of development. So there isn't a lot of flexibility when things happen, natural disasters or the COVID epidemic snarling up international supply lines. So I think we need a sustained policy approach towards addressing these issues. And that can involve both better oversight to understand when shortages threaten to occur or when they're in the markets in which the shortages are likely to occur. It can involve investment in improved manufacturing by either direct investment from government sources or through tax breaks. And I think encouraging manufacturing of essential products in the United States can help try to ensure that supply chains aren't reliant on products making the long voyage from around the world. So I think the best ways to do that would be greater investment in local manufacturing facilities. I would say tariffs, which have been proposed in the last few months as a way of dealing with this, is not a very good mechanism for dealing with this because they're so fickle. They appear to be imposed one week and then taken away the next week. And that's not really a sustained approach towards dealing with this issue. So I think that this is a really important issue and one that's really complicated and one that will take a sustained and consistent approach towards trying to fix.
All right, let me change topics again. Let's go to some of the innovation that perhaps unexpectedly emerged during COVID, right? So during COVID, we saw direct-to-consumer platforms, compounding pharmacies linked with telehealth. How should we be thinking about some of these new developments that emerged during COVID in terms of safety, in terms of the extent to which they actually help solve some of the current problems, and also in terms of their implications for equity?
Certainly, there are a lot of ways that telehealth can be very helpful in trying to bring useful, high quality medical expertise to people who might not have the access to that. So, I'm very supportive of efforts made during COVID to try to improve the availability of telehealth medicine. And, unfortunately, it seems like we've walked that back a little bit since the pandemic has receded a little bit. I think that that is a very useful mechanism for helping patients. I mean, I know that in my primary care practice now, I do a lot more telehealth than I did before COVID. And I think it's a very positive development and it helps people who otherwise might struggle to come in to see me as a primary care doctor. You mentioned direct to consumer drug selling platforms as well. I think those are more problematic in part because those programs aren't necessarily designed to get essential medicines to the patients who need them, but are designed around particular types of drugs. And so there's not really a good alignment with the public health needs that patients have. And a number of companies have set up their own direct to consumer platforms for their own brand name drugs, which is really just a way of trying to sell high priced products to a very small number of people who can afford to use those platforms. So, those kinds of platforms are not necessarily a solution to the problem of drug prices or access to medications for now. I think they could be down the road, but it doesn't seem like that's the primary role they're filling right now.
Let me jump to the discussion that's been emerging and becoming more and more visible in both public and academic space about linking what we pay for drugs with how well they work and using mechanisms like value based purchasing and outcomes based contracts. So, what's your sense of the feasibility of these models in the US? And what's the evidence that they do work when implemented?
Well, I think that there is a lot of promise for these kinds of models. Fundamentally, this is what every other high income country in the world does, which is that after a drug is approved by the regulator, there's a process of negotiating the drug's price based on the benefits that the drug provides. And we don't do that in the United States. And as a result, drugs are priced at whatever manufacturer wants it to be. And so, in response to that, there have been efforts to try to say, well, maybe if the drug doesn't work down the line, the manufacturer can like give back some of the upfront spending. And there's some promise there, but unfortunately, that's a very complicated system. And ultimately, it's really challenging to follow up on patients appropriately and to ensure that there's adequate reimbursement at the end of the pathway. I think that the best solution would be to pay upfront or to negotiate upfront what a fair price is based on knowledge about what the drug can provide. And as a backup to that, we're setting up these value based contracts that are challenging to implement and don't provide the same level of fair pricing that an upfront negotiation would. That being said, there are certain circumstances like very expensive, one time only cell and gene therapies that these kinds of models might be the proper pathway forward for a one time treatment for which there's supposed to be a long term response to it. So I can see these kinds of models working in those limited circumstances. But at least for now, the best bet would be to try to negotiate prices fairly upfront rather than relying on these kind of post hoc assessments of outcomes.
Many of the inefficiencies in the pharmaceutical system come from limited transparency around rebates, clinical trial data, or manufacturing costs. What are your thoughts about the critical areas for reform around transparency, which could actually help us improve how the market functions and perhaps build trust in the market around pharmaceuticals?
Yeah, I think there's a lot of ways that transparency can help improve trust. We've written a lot about transparency at the FDA and how greater insight into aspects of regulatory decision making can help provide trust and credibility in the decisions that are made by the regulator. I think that greater insight into pricing of drugs and the ways that rebates are negotiated on drugs can help provide a greater understanding of the actual prices that manufacturers receive and that payers pay for. And that kind of transparency can help us move towards a system that helps promote the efficiency of these drugs price negotiations to try to ensure that there's fairness. I think that transparency is an essential step towards fairness and efficiency. And so while I understand that there are limits on transparency around trade secrets and other business practices, I think that too often we interpret a lot of things as being trade secrets that aren't really trade secrets, and that actually might help improve the efficiency of the system and the fairness of prices if we had more insight into them.
What can we learn from other countries, high-income countries or other countries really, about drug prices and access? Are there particular international models that you think we can realistically adapt or at least adapt pieces of?
Yeah, I think so. One of the major lessons we can learn from other countries is how to assess drugs' value and use that assessment as part of the process for negotiating fair prices for drugs. That's again what every other high income country does except the United States after a drug is approved. I think that at the same time, other countries have payment and insurance systems that allows patients to get the essential medicines that they need without concern for high out of pocket costs. And so I think that trying to understand how other countries provide coverage for the drugs that they negotiate prices for can help provide a model for better systems for drug coverage that we have in the United States. Right now, I think something to the effect of 3 out of every 10 patients report that in the last year they had problems affording medication. And that's a function both of the high prices of drugs, but also of the health insurance system that we have that puts a lot of the out of pocket costs on the backs of patients. And so I think that we need to be thinking about how to deal with both of those issues.
What are your thoughts about the discussion about limiting direct-to-consumer advertising for drugs?
I think that it would be useful to limit direct to consumer advertising for drugs. I think that there are a lot of problems with direct to consumer advertising in how it tends to overemphasize the benefits of drugs and underestimate its risks. And I think that it's not an effective or efficient way of educating patients about prescription drugs. I think that first off, imagining the US without direct to consumer advertising seems a little bit fanciful right now with the way that the courts are interpreting the First Amendment's protection of commercial speech and the vigorous defense that pharmaceutical companies have traditionally put up in this area. So I would say that's one caveat to my statement. And a second caveat to my statement is that if we are going to move in that direction, that it would be useful to replace direct-to-consumer advertising with a real, meaningful, useful way of educating patients about prescription drugs, what drugs are useful to them and can really help them, and how to stay adherent to those medications, what drugs are not very valuable and that they don't really need as much. And so I would say that if we are going to move in that direction, that thinking about how to better communicate about drug risks and benefits to patients is an essential thing that we need to do to replace direct-to-consumer advertising.
What gives you hope about this area in the moment?
Well, it's bleak times right now in public health, and it is challenging to find areas for hope. But I would say that, first off, the implementation of the Inflation Reduction Act continues to be successfully done in terms of helping, negotiate the prices of a few drugs. And I think that if you ask people, like if you poll people in the United States, 75% of them will tell you that drug prices are too high and that we need to do something about this. And so that to me means once we do get an effective government and healthcare system in place, that there is a lot of consensus about the things that we need to do to try to make it so that people can fairly access the medications that are essential to their health.
I'm Dr. Sandro Galea. I'm speaking with Dr. Aaron Kesselheim of Harvard Medical School and Brigham Women's Hospital. Aaron, thank you for joining us.
My pleasure.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com, jamahealthforum.com, or look for JAMA Network wherever you get your podcasts. Thank you, everyone, for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.